Today I'll be sharing some exciting proof of concept results for in vivo gene editing of hematopoietic stem and progenitor cells. Gene editing holds tremendous promise for the treatment of hereditary blood disorders such as sickle cell disease. Sickle cell is a global health challenge that affects millions of patients worldwide, often in parts of the world that have limited healthcare resources. It is caused by a single point mutation in the beta globin gene that causes adult hemoglobin to polymerize and red blood cells to clot. This leads to ischemic injury in almost every organ in the body, as well as severe pain. It is debilitating and often deadly. Standard of care treatments are limited, and although hematopoietic stem cell transplantation can be curative, it carries its own risks and is only used in severely affected patients. Recently, ex vivo gene editing of a patient's own stem cells has demonstrated clinical benefit in a small trial, and this is incredibly exciting both for patients as well as for the gene editing field. The challenge now is to figure out how to improve access to this exciting technology for all patients suffering from sickle cell disease. The ex vivo approach for gene editing of bone marrow cells has significant limitations. First, it requires a complex cell manufacturing process. Cells are mobilized and harvested from patients, shipped to a central processing facility where they are sorted, electroporated with CRISPR, expanded, tested, frozen, and shipped back to the patient. In the meantime, the patient receives chemotherapy to myeloablate their remaining bone marrow to make room for the edited cells. This is associated with immunosuppression, which can predispose to serious and sometimes life-threatening infections. It is also associated with a risk of malignancy related to the chemotherapy drugs and a risk of infertility. As a result, this approach is not likely to become a mainstream treatment anytime soon, but rather to be used in select patients with severe disease in wealthy countries. The treatment complexity will also limit access for patients who live in resource-poor settings. What I'm going to tell you about today is a different approach that has the potential to overcome many of these limitations by performing the editing of bone marrow cells in vivo within the patient using a non-viral CRISPR delivery system. In this approach, the patient would receive an IV infusion of lipid nanoparticles, or LNPs, that would edit the patient's hematopoietic stem cells in their own body. As such, there would be no need for myeloablative chemotherapy or the associated risks of immunosuppression, malignancy, and infertility. There would also be no need for a complex cell manufacturing process or for extensive supportive care post-treatment. As a result, this approach could become mainstream therapy for sickle cell disease patients, and the treatment simplicity could also greatly expand access to patients in resource-poor settings. There are a number of desirable features of an in vivo approach such as this, including that it would provide clinically meaningful, durable HSC editing, allow for multi-dosing to reach a therapeutic target, preserve the regenerative potential of edited cells, and be fully translatable to the human HSC population. A non-viral approach to delivering CRISPR-Cas9 has well-recognized advantages, especially around the transient nature of expression that it provides and the low immunogenicity, which enables multi-dosing to disease-relevant cell types. It also has manufacturing tractability that is not currently achievable with viral approaches, and of particular utility is the tunable tropism that we've recently explored as a means to edit cells in the bone marrow. Importantly, editing hematopoietic stem cells in vivo requires LNP formulations with increased tropism for bone marrow. Most LNPs have been optimized for delivery to the liver, and as such are not as effective in reaching the bone marrow. We have set out to identify LNP formulations with increased tropism for bone marrow in mice, and on the next few slides I will share proof of concept results that we've generated with one particular formulation that looks promising. Using a bone marrow tropic LNP, we were able to achieve dose-responsive levels of editing in both whole bone marrow as well as the more primitive hematopoietic stem and progenitor cell population. In this experiment, wild-type mice were treated with a single dose of lipid nanoparticle administered at either a low, medium, or high dose. These doses are all well tolerated in mice and are consistent with doses that we have evaluated in the past for liver editing. Editing in the HSPC population is either equal to or slightly greater than editing in the whole bone marrow, which is important because HSPCs are the cells that will provide a long-lasting effect and give rise to all other blood cell types. As a reference point, around 20% editing is predicted to be curative for sickle cell disease clinically, which we are able to achieve in these animals using the mid or high doses of LNP. We next wanted to assess whether the editing that we were achieving was in fact durable, indicating that we were hitting the long-lived stem and progenitor cells, or if the editing would go down over time. To assess this, we performed a 1-year durability study in which a group of mice were dosed with a bone marrow tropic lipid nanoparticle at time 0, and then some mice were taken down and assessed at each of the time points shown in the figure. The guide that was used in this experiment is different from the guide that was used in the prior experiment, which is why the editing does not match. We assessed editing in both the whole bone marrow as well as the true HSC population, which is even more primitive than the HSPC population shown on the prior slide. We observed that editing was similar across all groups of mice, regardless of when they were taken down, suggesting that we were indeed hitting the long-lived stem cell populations and that these cells were not being selected against. Because we're using a non-viral approach to deliver CRISPR-Cas9, which has limited immunogenicity, we next sought to evaluate whether we could boost editing through repeat LNP administration, something that would not be possible with a viral approach. In this experiment, we dosed wild-type mice with the same dose of lipid nanoparticle either once, twice, 3 times, or 4 times, and then took the animals down and assessed editing. We found that the editing did increase in a stepwise manner with each successive administration of LNP in both whole bone marrow as well as the primitive HSC population. This is a really important finding because it suggests that we may be able to use multi-dosing to increase editing in a treat-to-target approach if we're not able to reach the clinical threshold with our first LNP administration to a patient. This could also avoid the need for any in vivo selection of edited cells using chemotherapy, an approach that has been described in the field. Next, to ensure that the in vivo edited cells still function normally, we performed a competitive transplantation study. Here we first edited the cells in wild-type mice and then transplanted those cells into recipient mice that received an equal number of cells from an untreated donor mouse. In this way, we could compare whether the edited cells were able to function as well as the unedited cells, or whether they would be outcompeted. After waiting 14 weeks to allow for proper engraftment of the transplant, we found that editing was unchanged in the bone marrow, suggesting that the edited cells were healthy and thriving. We also assessed the lineage distribution of cells derived from the in vivo edited animals and saw a normal distribution with appropriate levels of T cells, B cells, and myeloid cells. Not shown, but we also assessed the chimerism in these animals and found it to be roughly equivalent, with cells from the treated animals making up about half of the peripheral blood cells at the time of harvest, as expected given the 1-to-1 ratio of donor cells used. This was encouraging as it provided evidence that the in vivo edited cells retained their pluripotency and were able to reconstitute a healthy bone marrow. Lastly, to assess whether in vivo bone marrow editing would translate to human cells, we used mice that were transplanted with healthy human CD34 positive cells, a population that is enriched for stem and progenitor cells in humans. After allowing time for engraftment, we administered a single dose of lipid nanoparticle via tail vein and took the mice down 1 week later. We recovered the human CD34 positive cell population from the mice and observed over 20% editing in that population, suggesting that the bone marrow tropic lipid nanoparticle is able to deliver to human stem and progenitor cells in vivo in this model. In summary, LNPs appear to be well suited to deliver CRISPR-Cas9 to hematopoietic cells and to achieve durable in vivo gene editing. We were able to achieve clinically relevant levels of HSC editing in wild-type mice, and we also demonstrated that multi-dosing of LNPs increased editing in a stepwise manner, potentially enabling a treat-to-target therapeutic approach. Edited cells retained regenerative potential and reconstituted primary hematopoietic lineages, suggesting preservation of normal function. We also achieved therapeutically relevant levels of editing of human CD34 positive cells in a xenotransplant model, highlighting the cross-species translation of this approach. As a next step, we plan to demonstrate relevance of this approach to future clinical application by confirming activity in a non-human primate model. Thank you.